It's wonderful to see so many people here, including a few familiar faces, which I can see despite my reading glasses being on. And I'd like to thank very much all the organisers for giving me this opportunity to share our research with you all. So in this presentation, I'm going to be focusing on what academics refer to as research impact. And this really means looking at the ways in which our findings might be mobilised beyond the university to make some kind of improvement in how society works. And the collaborative study I'm going to be talking to you about today was designed from the start with that kind of impact in mind. We were funded by the UK's National Institute for Health Research to explore whether and how patients were being offered choice in their real interaction with doctors in the NHS. Now, patient choice is actually enshrined in the NHS Constitution, including in your most fundamental right to accept or refuse any kind of treatment that is offered to you. But the commitment to increasing patient choice has been part of a much wider vision for a modern NHS for the last 2 decades. And we can see there Sir Nigel Crisp, who was the chief executive for the NHS back in 2005, making the argument that there was a real ambition within the NHS to change the whole system. And as he puts it, there needs to be more choice, more personalised care, and real empowerment of people to improve their health. Now, these sorts of ambitions can be really inspiring, but they are broad brush, and I think many of us will have experienced them as being notoriously difficult to implement, and also potentially having some unintended consequences. So our study set out to understand what patient choice might look like if it's being enacted in a real consultation. And what we did to handle that was to record these real consultations. So we recorded with video and audio recording equipment over 200 real neurology outpatient consultations with 14 neurologists based in 2 big neuroscience centres, one in Scotland and one in England. And we used a research methodology known as conversation analysis, which is now widely recognised as being the gold standard for understanding how interaction really plays out in real interactions. And what we found in our recordings, to put it simply, was a really striking contrast. So sometimes we had exactly what you might expect, which is the neurologists making a recommendation for some kind of treatment that they thought would be the best for the patient. But on the other hand, the neurologists, and you'll see less commonly, also sometimes gave the patients a choice. And they did this by listing different options and then seeking the patient's own view. Now, we tracked all the decisions across our entire data set, and what we found was that recommendations were significantly more common than option lists. So if we look at this at the level of the consultation, then what we see is that actually the vast majority of consultations that contained at least one decision also contained at least one recommendation. So that was really, really typical. Much less common was an option list. So about 20% of these consultations with at least one decision had an option list. Now that pattern remains exactly the same if we look at the level of the decision. So there were over 240 decisions in the set, more than one in some consultations. And you can see again, the vast majority of those were handled with at least one recommendation. In fact, option lists only occurred in just over 10% of decisions. So whichever way we look at this, really option lists were not common in our data set. And the question is then, what do we make of this? Well, if we go back to the NHS's vision, then it's really clear that patient choice is expected to go above and beyond just the legal rights that are accorded through the NHS Constitution. And the quote you can see on your screen is taken from an NHS patient-facing website about patients' rights to choose within the NHS. And as the quote says there, there's a hope that patients are going to be able to say, I have discussed with my healthcare professional the different options available to me, including the pros and cons, and where appropriate, whether to choose to not have treatment. So if we think of that as a vision, and that was articulated in 2019, then the implication of our research seems really quite straightforward. Doctors should be trained to use option lists in order to deliver on this vision. And indeed, we have actually produced such training. We teach option listing using an acronym to help doctors and medical students to remember the key elements of full-form option listing. And we summarize this as ALF, A-L-F, announce that there's a decision to be made, L, list the options, F, find out what the patient thinks or wants. Sounds easy, right? So at that point, you think, right, Merran's job is done, the research has revealed what we can teach doctors, and indeed, we've taught them. But there's a catch. Our focus on what actually happens in real consultations revealed that even when doctors use an option list, choice can be undermined in a variety of ways. And most obviously, it matters how the options themselves are actually formulated. And I'm going to talk you very briefly through what I think is arguably our most extreme case, where we have a neurologist talking with a patient who experiences seizures that have not yet been diagnosed. And this matters for the treatment. And what you can see on screen is the doctor actually listing two options. And first off, he says, do you want us to keep trying to record them so we're completely sure what everything is and we can maybe treat them? Or do you want to kind of just soldier on as you are? I can tell from the audience reaction that you don't need a degree in conversation analysis to realize that just one option is presented here as really being worth a try, and that's further monitoring of the patient's seizures. The alternative amounts to doing nothing, and is certainly presented as if it's not going to give the patient any sort of relief from her symptoms. Now, this is a real option list, and it occurs quite far into a much longer decision-making sequence that I don't have time to share with you today. But what we're seeing here, I would argue, is the neurologist using the machinery of option listing, presenting those two alternatives, but not really for the purpose of giving the patient a choice. Rather, he's pursuing a recommendation for monitoring that he's actually already made a couple of times in the consultation before we get to this point. Thus far, the patient has actually refused the recommendation, or more accurately, failed to accept it. I'm sure you won't actually be surprised, based on how this option list is worded, to hear that after this option list, she does finally go on to accept further monitoring. So I think we can see through real cases that option listing can be used to do things that aren't really quite about giving a patient a choice. Now, it's not just what the doctor has to say that matters. When things are said is absolutely crucial for how the decision-making plays out. And this can be rather more subtle and thus tends to be overlooked in more abstract models of communication that are not based on real cases. So we're going to consider one more case from our data set. And on the screen, you're going to see a rather more complex transcript than I've shown you so far. This one includes symbols that we use in conversation analysis to capture not just what was said, but how it was said. And there's not time to go into the details of all of those now, you'll probably be pleased to know. But what you do need to know is that the numbers in brackets are silences in tenths of seconds. And we bother with that level of detail because there's plenty of research to show that this really matters for our own interactional understandings of what other people are saying. For instance, if you look at the silence at line 56 of a second, that actually can be heard to be indicating some kind of trouble in the talk. In this case, reluctance to accept the recommendation. Now again, what you're seeing on screen here is really only a small part of a decision-making sequence that extends quite far back into the rest of the consultation. And it's important for you to know that what comes before the bit that I'm going to talk through in more detail quickly now is actually the first two parts of option listing, the A and the L of my lovely elf. So the neurologist has announced there's a decision to be made. He's listed two options. The patient can either take a course of steroids right away, so some tablets, or she can be referred to another specialist who might be able to recommend more specialized treatment. So the question that you're seeing highlighted at line 55 is really the third component of option listing, the F. the neurologist finding out what the patient thinks. So here's the catch. You'll get to know by now that I like catches. As you'll see on the screen, something actually intervenes before the listing and the finding out. So what you're seeing at lines 46 to 51 is not the list, but rather the neurologist recommending one of the options. As he says, I think a wee trial of a short course of steroids would make a bit of sense to me. I'm going to play this for you. I made somebody jump when I practiced this yesterday, so be prepared.
How about, I think whether or not you're seen by the MS specialist, I think if these are affecting you, if these are affecting what you're doing, my take on this would be, could they leave it alone? Yeah, they could. But I think a wee trial of a short course of steroids would make a bit of sense to me. Mm-hmm. How do you feel about that?
Yeah.
Okay. What I'd like to do is write to your own doctor.
If we focus on the patient's rather minimal responses, we can see that, again, she's actually failed to accept the neurologist's recommendation. So she's given that rather non-committal at line 53. And it's only after that the doctor tries to find out her views explicitly with that question at line 55. How do you feel about that? And notably, her response to that is actually not very well fitted to the question. Yeah is not an answer to how do you feel about that. Rather, she's responding to the recommendation that came before, and with some display of reluctance too. Note the I think at line 62. Again, what we're seeing here is the machinery of option listing being used. In this case, all three components of ELF are produced, but the third component is displaced by a recommendation. And this has interactional consequences. We've seen that the patient is responding as if to a recommendation rather than voicing her own views. So to conclude, it's really tempting to kind of look at these real-life examples and think, okay, what we need to do is to teach doctors to do option listing better. But there's yet a final twist to the tale. We also found through statistical analysis that patients were overwhelmingly more likely to accept a treatment if the neurologist recommended it than if they used an option list. And that's probably good news. After all, if you're offering choice, you would expect that patients should be able to say no. But this creates a kind of dilemma for doctors. On the one hand, they're charged with giving patients a choice, and that's seen as a good thing because people tend to fare better if they've been more involved in their care. But on the other hand, doctors have a duty of care to try and ensure that patients get the best treatment available. So if the patient's rejecting the thing that the doctor thinks is most suitable for them, then there can be a real pressure on the doctor to pursue acceptance. And actually, option listing works pretty well for doing that, as well as for offering choice. So where does this leave us? Well, if we come back to the impact of our research, we've created a training package that addresses these kinds of complexities by teaching doctors on the basis of worked examples like some of the ones I've just shown you today. And our training has been endorsed by NICE, the National Institute for Health Research, and has been positively evaluated by trainees who've taken our workshops and used our e-learning. And we've now shared this training quite widely with doctors and medical students across parts of England, Scotland, Northern Ireland, Brazil, which was really exciting going there, and the Netherlands. So this is an impact success story, I'm pleased to tell you. But in my very last 30 seconds, I'm conscious of the time. I wouldn't blame you if what you're sitting there thinking is, this is nice, but the NHS is in crisis. How can we possibly be asking them to add in yet another thing, offering choice? Well, here's a surprising and reassuring fact. In our data set, there was no significant time difference between those consultations that included choice and those that did not. And on top of that, the key to our training is to try to ensure that we're equipping doctors with greater choice themselves in terms of the tools that they can use when they're actually making real decisions with patients, rather than in some kind of abstract, idealized, perfect communication scenario. Thank you. I'm going to leave you with a couple of acknowledgements, partly to our funders, and partly because I'm only part of a much bigger team of neurologists, other researchers, some of who are based here at York, an e-learning specialist who's in the audience, and also a final appreciation to the doctors and patients who actually participated in our research. And a word of thanks to John Yates and Andy Rouse for their outstanding support in developing this presentation. Thank you very much.